Podcast 2 of the Pelvis and Perineum series, the Inguinal Canal. This podcast is going to detail the Inguinal Canal, its formation, contents, and relevance to inguinal hernias. So to start off with, before we detail the Inguinal Canal, we need to briefly look at the muscles of the anterior abdominal wall. So the anterior abdominal wall is made up of 4 pairs of flat, sheet-like muscles. From superficial to deep, these are external oblique, internal oblique, and transversus abdominis. All of these muscles become aponeurotic towards the midline, where they form the rectus sheath, which surrounds the paired rectus abdominis muscles. I won't detail these any more here, but if you want more information, then you should look back at an earlier podcast. If we now turn to the inguinal region, then this region is located at the inferior margin of the anterior abdominal wall, between the anterior superior iliac spine and the pubic symphysis. It is of particular surgical importance due to it being a common site of herniation. Within this region is the inguinal canal. This is an oblique passageway formed from the various layers of anterior abdominal wall muscles, which allows the spermatic cord to pass between the perineum and the pelvis. This site is therefore of paramount importance in the male, as sperm, which are produced and stored in the testes, need to be delivered to the urethra. This canal permits this connection between the testes in the perineum and the urethra in the pelvis. The inguinal canal is only about 4 centimetres long and has 2 openings at either end. These are the deep and superficial inguinal ring. The deep inguinal ring is found more laterally, and it lies on the lateral side of the inferior epigastric artery. The superficial ring is more medial and is found slightly above and lateral to the pubic tubercle. The superficial ring is a small split in the external oblique aponeurosis, with the margins of the opening known as crura. So there is a medial and lateral crura. These crura anchor the superficial ring in place, with the medial crura attaching to the pubic crest and the lateral crura attaching to the pubic tubercle. Running superior to the superficial inguinal ring and joining the medial and lateral crura are intercrural fibres. These are important in preventing the superficial inguinal ring from splitting and becoming larger. Although the inguinal canal is usually collapsed, lying on its contents, it does have 4 boundaries. There is a floor, a roof, and an anterior and posterior wall. The floor of the inguinal canal is the inguinal ligament. This is a dense band of tissue formed from the inferiormost aspect of the external oblique muscle. This ligament extends from the anterior superior iliac spine to the pubic tubercle. Although most of the inguinal ligament's fibres attach medially to the pubic tubercle, some of the fibres pass posteriorly and attach to the superior pubic ramus, and these fibres form the lacuna ligament. Its anterior wall is formed from mainly the external oblique muscle, with the lateral third of the anterior wall also formed from internal oblique fibres. The roof of the inguinal ligament is a little more complicated, with both the internal oblique and transverse abdominis muscles arching posteriorly over the canal. As internal oblique forms the anterior wall most laterally, as this muscle extends medially, it arches posteriorly to form the roof, and it does this along with transversus abdominis muscle. As these muscles arch over to form the roof, they merge together, forming the conjoint tendon. This conjoint tendon then forms the posterior wall of the inguinal canal, directly behind the superficial inguinal ring. So the conjoint tendon is formed from the arching fibres of internal oblique and transverse abdominis as they merge together and end attaching to the pubic bone directly behind the superficial inguinal ring. The more lateral parts of the posterior wall are formed from the transversalis fascia. So just to repeat those boundaries, the floor is formed from the inguinal ligament. The anterior wall is formed from mostly external oblique, along with internal oblique more laterally. The roof is formed by the posteriorly arching internal oblique and transverse abdominis fibres, and these fibres merge together and form the conjoint tendon posteriorly, behind the superficial inguinal ring. The remainder of the posterior wall is formed by the transversalis fascia. So now let's detail the contents of the inguinal canal. Within the inguinal canal is the spermatic cord and an important nerve. Dissection of the spermatic cord can reveal an array of structures that all pass through the deep inguinal ring to enter the canal and leave the canal via the superficial inguinal ring to enter the scrotal sac. These include the vas deferens, the testicular artery, a small artery to the vas deferens, the pampiniform plexus of veins, autonomic fibres, and the genital branch of the genitofemoral nerve. Importantly, whilst the genital branch of the genitofemoral nerve is located within the spermatic cord, the ilioinguinal nerve also runs within the inguinal canal, but importantly, it does not run within the spermatic cord. This nerve arises from the L1 level and runs around the anterior abdominal wall, alongside the anterolateral abdominal wall muscles, to run within the inguinal canal and pass towards the scrotum. The ilioinguinal nerve supplies the anterior aspect of the scrotum, but importantly, it doesn't run within the spermatic cord. As the testes passed through the inguinal canal during testicular descent, these numerous structures trailed behind, and the spermatic cord took on several coverings as it pierced the anterior abdominal wall. There is the external spermatic fascia, formed from the external oblique aponeurosis, and the internal spermatic fascia, formed from the transversalis fascia. Between these is the cremaster fascia. This is derived from the internal oblique muscle, and this also gives rise to the cremaster muscle, a thin layer of muscle wedged in between the external and internal spermatic fascia. In the female, the spermatic cord is replaced with the round ligament. As I'll detail in a later podcast, this ligament originates from the uterus and ends up attaching to the labium majorum in the female by following a similar path to that of the vas deferens. It is considerably smaller than the spermatic cord, and because of this, the superficial inguinal ring is smaller and in the cadaver a lot harder to find. So to finish the podcast, I just want to go over some details relating to inguinal hernias. The inguinal region is surgically important due to the high level of hernias found within the inguinal region. Remember, a hernia is a protrusion of a structure from a region where it's normally located to an abnormal region, normally through a hole or an aperture. In the case of the inguinal region, this could be a piece of small intestine penetrating through the anterior abdominal wall. A lot of hernias are reducible, meaning they can easily be manipulated back into their original position. Approximately 80% of all hernias are located in the inguinal region, and these can fall into two types, either direct or indirect. The indirect hernia usually results from a weakening of the anterior abdominal wall at the inguinal triangle region. This is a specific area bordered laterally by the inferior epigastric artery, medially by the lateral edge of rectus abdominis, and inferiorly by the inguinal ligament. A weakness here means that increases in intra-abdominal pressure can cause the small intestine, or another part of the abdominal viscera, to push against this weakness, potentially allowing this piece of viscera to exit the abdomen through the anterior abdominal wall. And this usually occurs at a site near the superficial inguinal ring. A weakness here means that increases in intra-abdominal pressure can cause a small intestine to push against this weakness, potentially allowing the piece of viscera to exit through the superficial inguinal ring. Importantly, the herniating piece of viscera doesn't actually penetrate the layers of anterior abdominal wall, but pushes against them, like when you push your finger through an inflated balloon. You push through the balloon, but do not actually pierce it. Due to this restriction, this type of hernia rarely enters the scrotal sac. An indirect hernia is associated with the deep inguinal ring and is due to the patency of the processus vaginalis, a structure associated with the descent of the testes. If this structure fails to diminish, it maintains a pathway from the abdomen and pelvis into the scrotum via the inguinal canal, and viscera can therefore enter the canal via the deep inguinal ring and migrate down the inguinal canal. Because the herniating structure is not limited like a direct hernia, it can pass through the superficial inguinal ring and fill the scrotum. This is obviously serious. If the piece of herniating tissue becomes strangulated, it can become necrotic and cause infection. So in this podcast, I've detailed the boundaries and contents of the inguinal canal and briefly looked at inguinal hernias. In the next podcast, number 3, I'll look at the pelvis and its peritoneal reflections.